Marissa Henderson, U.S. University, MSN 570. Carl Hastings is a 74-year-old male that came in with a complaint of movements of his hand he can't control and trouble when walking. He states he has had uncontrolled movements of his left hand for the past 3 weeks, trouble standing, and feels very clumsy. He stated his brain just feels foggy all the time. Patient has a past history of migraines and kidney stones. He had a kidney lithotripsy in 2009 and an umbilical hernia repair at age 34. His father had kidney disease and mother was diagnosed with Alzheimer's at age 65. He stated that he is always sweating and seborrheic dermatitis was noticed along his hairline. He has had orthostatic hypotension on his exam, but a past history of hypertension. Patient denies nausea or vomiting, but has complaints of struggles with defamation and is using an over-the-counter stool softener, which he states is currently not working. He is not pooping more than once a week. He struggles to urinate with a past history of kidney stones. He has diffuse pain throughout bilateral arms and legs and states that he is always just tired and does not want to do much. He denies any fainting or dizziness. Wife states he struggles to walk and his walk has changed drastically in the past 2 weeks. There's a noted weight loss of 17 pounds since his last visit, which was 6 weeks ago. Patient has not been dieting and drinks 4 to 5 Pepsis a day. Patient denies any smoking or alcohol use, and he has 4 children that all live in the area. I performed the trap screening on Carl. He has a resting tremor of the left hand that stops when he is asked to move around his hand. He has small jerks of his body during examination and uncontrolled movement of his hand during the exam. He was trying to rest his hands on his thigh to prevent involuntary movements. It took the patient 4 times to be able to stand up from his chair. 3 times he fell back into his chair, and the 4th time he fell sideways onto his wife. Once he was standing, his trunk was leaning forward, and when asked to walk across the room, the patient shuffled with very small, quick steps and struggled to stop. I am concerned that this patient is showing signs of a certain disease, but I would like to have you go in and see if you formulate the same diagnosis. Parkinson's disease is a complex motor disorder accompanied by systemic non-motor and neurologic symptoms. The main disease feature is degeneration of the basal ganglia, the corpus striatum, globus pallidus, subthalamic nucleus, and substantia nigra, involving the dopaminergic, dopamine-secreting nigrostriatal pathway. The pathogenesis of primary PD is unknown. There are several features that have been associated with Parkinson's disease at this time. The hallmark pathologic features of PD are loss of dopaminergic pigmented neurons and the substantia nigra, pars compacta, with dopaminergic deficiency in the putamen portions of the striatum. The striatum includes the putamen and caudate nucleus. As you can see in the photo above with Parkinson's disease, there is a decrease in functioning of the neurons. This causes less dopamine to make it to the receptors, which causes a movement disorder, Parkinson's disease. Lewy bodies, fibrillar intracellular eosinophilic inclusions, and high concentrations of alpha-synuclein, ubiquitinin, tau protein, tuberculin, and other proteins are found in the substantia nigra, locus coeruleus, and other areas of the brain. They are a marker for neuronal generation. The basal ganglia is located in the middle of the brain near the brainstem. It is the part squared off in red in the picture above. The basal ganglia include the striatum, which comprises the caudate nucleus, putamen, and nucleus accumbens, the globus pallidus that is divided into an external segment and an internal segment, the substantia nigra that can be divided into a pars compacta and pars reticulata, and the subthalamic nucleus. There are both input and output regions of the basal ganglia. The input is what receives information to the basal ganglia, and the output sends messages to other parts of the brain. The pathophysiological hallmark of PD hypokinetic signs is the prevalence of the indirect pathway over the direct one, which results in increased neuronal firing activity in the output nuclei of the BG and leading to excessive inhibition of the thalamocortical and brainstem motor systems, which is interfering with normal speed of movement onset and execution. There are some biomarkers that are said to show the progression of Parkinson's disease in a patient. Findings from the review suggest a convergence of evidence that low baseline AB42 in the CSF of non-demented PD patients predicts development of cognitive impairment over time. Conversely, there is limited evidence that CSF levels of TAUs, either total or phosphorylated tau, is a useful predictive biomarker. There are also mixed results for other CSF biomarkers such as X-synuclein, neurofilament light chain, and heart fatty acid binding protein. You might be thinking to yourself, why is finding this out important for a PD patient? This would be invaluable to the initiation of early treatment and clinical management of this devastating symptom. If we know that someone is on the course to developing cognitive impairment, we could potentially start treating these symptoms early. Bradykinesia is represented cranially by loss of facial expression, decreased frequency of blinking, monotonic and hypophonic speech, and drooling due to decreased spontaneous swallowing. Carl has stated to the doctor that he has been drooling without even noticing in the previous weeks. The pathophysiology of bradykinesia is not completely understood, but among PD cardinal signs, it is the one that fits better with the classical model of the prevalence of the indirect pathway over the direct one in the basal ganglia. This classical model means that the neurons start misfiring and cause the brain's stem motor systems to slow down or stop, which causes these slow movements, inability to move quickly, and could be some drooling. Parkinsonian tremor appears to result from instability of feedback from the basal ganglia to the cerebral cortex caused by loss of the inhibitory influence of dopamine in the basal ganglia. This is usually the first symptom that a patient will present with that has Parkinson's disease. This tremor is usually only at rest. When the patient is moving, the tremor will stop until the task is completed. The Parkinsonian tremor usually affects a patient's arm versus a leg and can be increased with stress and anxiety the patient may be having. The basal ganglia influence hypothalamic function, autonomic and neuroendocrine, through pathways connecting the hypothalamus with the basal ganglia and cerebral cortex. So with this basal ganglia having a disorder, it can cause disorder in our autonomic and neuroendocrine systems. This could lead to inappropriate diaphoresis, gastric retention, constipation, and urinary retention. Our patient is having 3 of these symptoms. The incidence of Parkinson's disease ranges from 8 to 18 per 100,000 persons a year, and thus identifying effective drugs that can slow the progression of Parkinson's disease is critical. L-DOPA, levodopa, is effective in reducing symptoms in early Parkinson's disease, but can cause motor fluctuations, off periods, and dyskinesia in the long term. A dopamine agonist will bind to the receptors and help raise levels of dopamine. Monoamine oxidase B inhibitors keep the body from breaking down the dopamine we currently have. And COMT inhibitors increase the half-life of dopamine, so they are used longer. Anticholinergic drugs and antihistamines are used to help with tremors in Parkinson's disease. There are other treatments available for Parkinson's disease patients. Thalamotomy and pallidotomy are surgical treatment options for Parkinson's disease. Deep brain stimulation, which is also a surgical treatment, can be done to help with dyskinesia associated with Parkinson's. Occupational therapy is another treatment that will be needed for patients with Parkinson's disease. As the disease worsens, so do the signs and symptoms associated with it. At the end stages of Parkinson's disease, the patient may be unable to walk and wheelchair bound, so they need occupational therapy to be able to do their daily living. Physiotherapy is another treatment that a Parkinson's patient will need. There is evidence that physiotherapy causes short-term, significant, and clinically important benefit for walking speed, balance, and clinician-related disability in Parkinson's disease. Just a few quick facts about Parkinson's disease. Usually the onset of PD occurs after 40 years of age with a mean onset of 60 years of age. It is the most common of primary central nervous system disorders. Over 60,000 people are diagnosed with Parkinson's every year, and an estimated 10 million people worldwide are currently living with Parkinson's disease. Men are more likely to be diagnosed than women, and unfortunately, median time between diagnosis and death is usually 7 to 15 years. After a second view-over by the attending physician, it is decided that Carl Hastings indeed does have Parkinson's disease. Genetic testing has been done and labs are on order. At this point, it's time to make a treatment plan for Carl Hastings. First, I will start with educating both Carl and his wife about Parkinson's disease. If he is unsure what he really has, it can make things even more difficult on Carl. He needs to know what to look for, what could happen in the future, the potential for this disease. There will be handouts given on Parkinson's disease, and a phone number will be provided to him in case he or his wife have any questions in the coming weeks, months, years. We will also be starting him today on levodopa to increase his dopamine and Benadryl to help reduce the symptoms of the tremor. Education and pamphlets will be given on both the medications levodopa and Benadryl. Carl is currently going to be set up for weekly occupational therapy and physiotherapy. If the condition starts to get worse, the physiotherapy will be increased weekly to maybe 2 to 3 appointments. At this point, we have his follow-up scheduled for 1 month from now to check on him. He is aware that if anything changes drastically before then, or even if he doesn't feel it's drastic but he needs a checkup, then he has to call and make an appointment. If it is an emergency, he knows to go directly to the ER. Carl has a family that is very involved and plans to help him through this. Thank you.